Ladies and gentlemen, welcome to the very first interview with experts international edition, proudly presented to you by the Malaysian Dental Student Association MDSA. My name is Darren, a member of the Academy and Research Team of MDSA. In this episode today, we are very honoured to have you with us Dr. Kian Meng. Dr. Tan is a prosthodontist or specialist dental group. He is also an adjunct lecturer of the National University of Singapore, a visiting consultant of the Singapore's Polytechnic Hospital, and currently the president of the Prosthodontic Society in Singapore. I'm currently in Dr. Tan's clinic, and let's welcome our very first international expert.
So hi Doctor, first on behalf of MDSA, I'd like to thank you for accepting our invitation to be our special guest today. So now let's move on for our questions. Doctor, so for our first question, what is the duty of a maxillofacial prosthodontist? Could you provide us an example of an ideal treatment planning with a case that suits your role?
Okay, first thing first, I would like to clarify that maxillofacial prosthodontist is actually an extension of a prosthodontist, meaning you can view it as a subspecialty of prosthodontics. That being said, that means you can be a prosthodontist, but not a maxillofacial prosthodontist. But you cannot be a maxillofacial prosthodontist without being a prosthodontist, right? So that means you have to have a very strong foundation in your prosthodontic work before you venture into the max fac scene. If you ask me what is my role, basically being a maxillofacial prosthodontist is not much different from being a prosthodontist, meaning we will need to be able to diagnose, treatment plan, rehab, and then provide necessary maintenance for the comfort, function, health, and aesthetic of a patient. And of course, if you look at maxillofacial prosthodontics, the defect is usually more complex. Okay, it's more complex not just in terms of size, but in terms also from variety. So, I mean, if you're looking at prosthodontics, you are dealing with missing teeth, maybe some deficient gingival, some tissues. But if you are looking at maxillofacial prosthodontics, the defects may include missing bones like the hard palate, or if you are dealing with extraoral defects, you may even have missing nose, missing ear, missing eye, and things like that. So if you ask me, what is my role as a maxillofacial prosthodontist? First, diagnosis, okay, you have to get it right, and then second, your treatment planning. Go through all the advantages, disadvantages of various treatment options, and then the risks, the limitation, the prognosis. Of course, financial counseling is important, and then after that, you look at the execution of the procedure itself, and then subsequently, we have to maintain whatever prosthesis that we deliver to the patient. So if you are asking more specific cases, I would say almost 90+% of my maxillofacial cases, they are within the intraoral area, meaning we have lesser extraoral defects nowadays because of preflaps. And for intraoral defects, mainly we are dealing with hard palate, the loss of hard palate, as well as resected mandible. Okay, so these are the areas that as a maxillofacial prosthodontist we should be quite experienced in dealing with it. Yeah.
Okay. So Dr. Afonso, for this role, right, do you collaborate with other specialists such as an oral surgeon?
Yes. So if you ask me what is the ideal setting, the best ideal setting technically would have to be in an institution or a hospital.
Oh,
okay. Even more important if you can be in the cancer center. Okay. So my background is I was trained in MD Anderson Cancer Center, so I can share a bit. In US, there are 4 major cancer centers or known, okay, to provide a very good maxillofacial prosthodontics training. One of them, of course, is MD Anderson Cancer Center. Then the other one is UCLA, okay, University of California, Los Angeles. Then you have the Mayo Clinic, which is also a famous center. And lastly, in New York, you have the Memorial Sloan Kettering. Okay, so these are the 4 centers that are still, until today, providing very strong 1-year fellowship for any interested prosthodontist to train in max fac prosthodontics. So if you want to do very ideal work, first you must be in an ideal setting, ideal team. Okay, so this team, who are the people in this team? We must have the oncologists. Okay, if you are talking about cancer, so you have the head and neck surgeon, you have the radiation oncologist, you have the medical oncologist, which basically provide the chemotherapy, and now of course you have people like us, the dentists or the max-fac prosthodontists. Then you have to also deal, sort of collaborate with people like speech therapists, dietitian, and then physio as well. Okay, so it's a very big team, and the important thing is we try to know what each member of this team do, so that we can complement the strength and the weaknesses of each other.
So doctor, it's basically like when as a maxillofacial prosthodontist, it's not like a very solo work, right? You work around with a lot of other like oncologists or maybe maxillofacial surgery. So it's like a collaboration, right?
Yes, and you cannot work alone because, like I said, the defects are too huge sometimes, and it's not just it's no longer just within intraoral. You have to also look into the medical morbidity as well as the mortality of that patient. Okay, because if just give you an example, if the patient has a very poor prognosis, okay, let's say, then of course your treatment has to be tailored to that situation, where it has to be minimum and sometimes even be palliative. You cannot be treatment planning your full mouth rehab in that kind of setting. Yeah.
Okay, doctor, do we agree that the prevalence of oral cancer has increased over the years?
Yes, that is true. Okay, traditionally, oral cancer falls into the category of, let's say, older men. Okay, that is the traditional demographic that we used to read and see, because the cause of oral cancer in the old days is basically alcohol and smoking. Okay, of course, you can also say that in some area of the world, for example, in South Asia, you may have bitter nut chewing, things like that. Whereas now, another group of oral cancer, which is basically the HPV-induced oral cancer, okay, that is affecting younger generation, and also it's also affecting more female patient, younger, as well as these patients who never smoke and drink.
Oh.
Yes, so it's interesting that you are seeing a different kind of trend.
Yeah. So doctor, so how would you help all these patients to battle oral cancer as a maxillofacial prosthodontist?
Okay, so what I would say is, let's define my role in three stages. Okay, that will be easier to explain. The first stage, of course, is the diagnosis and prevention. Let's put it this way. Okay, the thing about us, okay, be it a prosthodontist or a dentist, we see at least 10 patients a day. Let's put it an average. So if any of these 10 patients that you see, even for a routine procedure like a scaling and polishing, it would be appropriate for us actually to just have a quick screen of the oral mucosa. Okay, I think by doing that, you actually have a sort of a check for the patient. Okay, because the problem with cancer is late diagnosis. If you get the diagnosis late, let's say stage 4, then the prognosis will be poorer. Then you're looking at 50% survival and things like that. Whereas if you catch the cancer at, let's say, stage 1, then your survival could be as high as 90%. Okay, so that for the first row would be the prevention as well as the diagnosis. Of course, the diagnosis, if we see anything that is abnormal, okay, like for example, you see some erythroplakia or some leukoplakia, some white and red lesions, two things we can do. One is either you are very comfortable in doing a biopsy yourself, or second, appropriate referral. Okay, appropriate and timely referral. I think that is the key. Okay, let's talk about the second row. The second row means if I am dealing with a patient who is in the midst of cancer treatment, and for oral cancer, basically these are solid tumors. Okay, unlike things like leukemia, lymphoma, they are more the hematological lesion. So when you're talking about solid tumor, one of the key treatment would be surgery. Okay, so surgery of the oral cavity, definitely you need to replace the soft and hard tissues, and this is where our role comes in. Okay, then of course you also have to manage the side effect of radiation and chemotherapy, and that means you have to as a dentist or as a prosthodontist, you have to be able to explain to the patient what to expect, how to prevent it from getting worse, and how to manage and help them manage. That's the key. Okay, then we are talking about the last part. The last part is after cancer treatment. What is our role? Our role is, of course, to provide maintenance.
Yeah.
Okay, provide maintenance, because right now you must understand, after radiation, after chemotherapy, after surgical ablation of the tumor, the environment of the oral cavity is no longer the same. Alright, it's more difficult for the patient to manage. So that is where we come in and sort of help patients to understand their condition a bit better, and maybe tailor a more individual preventive or maintenance program for them. Okay, so I would say at different stages we have a role for these patients.
Okay, understand, doctor. Thank you for sharing. Now, moving on to our next question, doctor, you've been to like many different countries such as the USA for your masters. We are wondering that experts across the globe, do they have different perceptions in terms of treatment planning?
Okay, this treatment planning is a bit subjective, but at the same time it's also objective. Okay, objective is what you learn in school. I'm sure you were taught which at what stage this tooth can be safe or not safe. Okay, that is objective. You have some guidelines to sort of guide you. Okay, it's just like but then when you talk about the art of treatment planning, it can be a bit subjective, solely because it's based on, first, maybe cultural, second, maybe finances. Okay, I mean, for example, if you're in a big city where people can spend, then maybe the treatment may be biased towards a more complex type. Whereas in a very rural area where resources are limited, then the treatment planning can be a bit more simple and all that. Okay, that is the art of this dentistry and art of prosthodontics, which cannot be taught that easily. But if you ask me about education, about the academic side of it, the objective side of it, technically treatment planning is no difference. Simply because biology doesn't change. You agree, right? Biology. Let's say biology of a Caucasian versus biology of you is the same. Okay, healings will take the same amount of time in you as well as a Westerner, or let's say an Indian. Okay, so this is the same biology. Of course, minute differences in terms of anatomy, bone thickness, gingival biotype, those I mean I can accept. But largely in terms of treatment planning is not much difference. And one point I also note that because in Singapore and Malaysia we rely a lot on Western textbooks.
Oh yes.
This you would agree with me. So if you are reading from Western textbook, how much more different can you be in terms of treatment planning, right? So basically we are learning from the same cookbook. So the only thing that, like I said again, the only thing that can be different could be just because of the cultural differences, and as well as finance, as well as accessibility, resources. These are the things that maybe will change the treatment planning a little bit from country to country.
Okay. So doctor, just to recap, so basically you're trying to say that the objective treatment for no matter who that patient is, it will be the same, but they are also influenced by many different circumstances such as the financial status or maybe the technology available.
Yes.
Which is why the treatment perceptions may be different.
Yes, very good. You sum it up rightly.
Okay. Now doctor, moving on to the next question, because as a dental student myself and like maybe some dentists, if we encounter a complex case, we tend to refer them to experts such as a specialist. But what if have you ever encountered a complex case that you yourself are not familiar with as a specialist?
I mean I can say that until now there are still some cases where it's really out of the box, out of the textbook, things that you have not seen, because conditions they come in various situations and all that. One thing I always remember is when you learn, or I learn, okay, when I learn, always fall back to principles. Okay, I think that is key, because if you fall back to principles, then technically a lot of things can be sort of expand and follow up from there. Okay, let me give you an example. last year I had a patient who was diagnosed. This patient is a South Asian from India. Okay, he was diagnosed with mucormycosis. I don't know whether you read the news where India actually has a lot of this black fungal.
Yeah, black fungal.
Black fungal infection. Yes, because of COVID, the heavy use of steroids and things like that. So this gentleman, he had a very bad mucormycosis infection. Okay, basically the entire heart palace was infected, and he had one round of surgical resection of the heart palate in India. Okay, so of course the fungal infection didn't leave him, so he was still very sick and all that. He flew to Singapore to get treatment, was seen by one of our top ENT here. Then of course the heart palate was already resected. Okay, so there's a problem there, and he cannot swallow, he cannot speak well because there's an oral nasal leakage. So I was roped in by the ENT to help out. So if you ask me, have I seen any mucormycosis before? The answer is no, because it's not common in this part of the world. So what we do is, what I did was basically to fall back into the principles and how to manage it. Probably not much different from, let's say, dealing with an obturator cases and all that. Okay, the aim is to be able to get a good seal. Of course, on top of this is to be able to, for the ENT and myself, to make sure that all the tissues are healthy, right? For advice, if maybe for you, a young dentist to be, in future, if you notice any difficult cases or cases that you have not seen before, PubMed is one of the resources, one of the resources that you can use to actually look for case report. I myself find that very useful, because case report, usually they write on very interesting cases. Yeah. Okay, if you Google case report and all that, they write on very interesting cases, and you may be able to find a very similar or even the same case that talks on that particular condition. So by looking at the case report, you can probably get some idea on how to manage that case or that situation yourself. So I think that would be one advice I would give to dentists to be like yourself. And I still remember my program director, Dr. Carl Driscoll, very smart guy. He used to tell me, if you encounter a prosthodontic case, okay, a prosthodontic case that you don't know how to treatment plan, don't worry. Just get a set of nice alginate impression, mount the case up, okay, on an articulator like this, stare at it long enough, the answer will come. Yeah. Okay. So I still remember that. That to me actually worked, because if you don't know what to do, get a nice set of impression first, mount it up on the articulator. Okay, of course you can get it at the correct vertical dimension, get it at the correct central relation, then stare at it long enough, you may be able to find something. Yeah.
Okay, understand. So actually, doctor, even my lecturer has mentioned before, like, no matter how complex the treatment planning gets, the basic fundamentals will always remain the same.
Yes.
So do you agree that if we encounter a complex case, we need to go back to basic and see what are we trying to achieve?
Yes. So again, the principle. Okay, you need to know what are your boundaries, what can be done, what cannot be done. Not because that case is complex, you try to impose a more complex treatment. Okay? I'm sure you heard of this KISS rule, right? KISS.
Oh, this one, yeah.
Keep it simple, stupid, yeah. Right? Keep the treatment simple and stupid.
Yeah.
It's not wrong, because a lot of these things that were said by the so-called our mentors, or all the giants that were before us, it still rings true today.
Okay, understand. So, doctor, for our last question, is actually a popular question that we have in Malaysia. After being a specialist, some believe that you may be cut off from other specialties because you are only specializing in one field. So, how would you advise a dental student or a dentist who is interested in multiple different specialties?
Okay, I think one should not take that view as the truth. And having said that, I also don't see anything wrong, one being a general dentist. If one is really truly enjoying, various disciplines of dentistry, then being a general dentist is the way to go. But of course, if you want to be a specialist, you have to understand why you are doing so. And I think the biggest drive is passion. Okay, if you don't have the passion, it's very hard to pursue that path. Because nowadays, for you to be recognized as a specialist, you have to go through a 3-year program. Okay, I'm sure it's the same in Malaysia, in Singapore. Anything less than 36 months of training is not counted.
Yeah.
Okay, so if you do that, you need to ask yourself, are you ready for this? And of course, I can only say for prosthodontics. In fact, to say that prosthodontics is being cut from all other specialty is probably the least true, because prosthodontics,
it's involved in many.
Yes, you deal with a lot of different specialists. Okay, within dentistry, let's not talk about cancer and all that. Just within dentistry, we deal with endodontists, periodontist, oral surgeon. You know, especially when it comes to restorations of teeth, as well as replacement of teeth via implants. You deal with so many peoples. Even orthodontists, you know, we deal with them, especially for kids with congenitally missing teeth. As a prosthodontist, I would say we have a good breadth and depth of knowledge in the whole sort of stomatonetic understanding. So that I think it's quite a fulfilling specialty if you ask me.
So you think prosthodontist is the best specialty if you're interested in many different fields, because you're involved in almost every specialty you need to consult a prosthodontist, right?
Yeah, I mean, if you say best or not, but again, I think you have to have the passion for it. Okay, you have the passion for it, because like I said, prosthodontist, you have to have not just the understanding, but you have to also have the mean to execute the treatment. Okay, meaning you basically have the whole package, if I can say that way. Yeah.
Now, here comes the most exciting part of the interview, the rapid fire round. So doctor, I'll be asking you 7 questions and you have to answer them as quickly as possible.
Okay.
Is that okay?
Okay.
Are you ready, doctor?
I think so.
Okay, doctor. So for our first question, would you prefer a denture or an implant to replace your edentulous space one day?
Implant.
Implant. Okay. So doctor, if you are given a choice, would you consider other specialties?
No.
No. Okay. So for the third question, doctor, do you agree that teaching will make you a better dentist?
Yes, for sure.
Okay. So, doctor, in your opinion, if a dentist aspires to only provide the best possible treatment for the patient, which sector do you think it's the best for that dentist? Should he work in government, private, or in the institution?
I would say no difference. Really no difference, because different patients in different sectors deserve the best treatment. Yeah.
Okay, understand. So doctor, if you are stranded in a new clinic, you could only bring one staff with you. Would you bring your technician or your DSA?
I would, well, if it's a quick one, I would say bring the DSA, because I can do quite a bit of lab work myself. Yeah.
Okay. So doctor, for the 6th question, what's the aspect of prosto that you dislike the most?
Prosto that I dislike the most? Wow. Actually, is to really see our own failures. It's something that we dislike the most, but I mean, for all young dentists out there, complication is part and parcel of our prosthodontic work. So that I dislike, but I still have to face it.
Okay.
Yes.
Now, for our final question, doctor, should a dentist invest more in materials and equipment or courses? Basically, better skill or better materials?
I would say definitely not material, better skill. Okay, and that skill, like what I said earlier, it still fall down to principles. Allow me to do a rough quote of one of these quote that still rings in my ear, is that technique, okay, or skill is merely an application of principle. Okay, see if you agree. If the technique is not based on sound principles, no matter how complex or how time-consuming that procedure, it's doomed to fail.
Okay.
Okay, so I think it's a simple choice, it's a simple answer. I will still go for the principle and the skill.
Okay,
Yeah.
I understand. So doctor, thank you for the very inspiring interview, especially mentioning to us that even experts across the globe, they have different perceptions of treatment planning, but the main objective remains the same.
Yes.
So I guess that concludes our interview with experts, international edition. We hope you enjoy it, and we hope to see you again soon. Okay?
Alright.
Thank you.
Thank you, doctor, for the interview.
I see at what point I can furnish you some